So now we'll discuss a short topic, that is the endocrine changes occurring in HIV infection. So you can expect probably one question from this area in the INISS exam. So the endocrine involvement in a patient with HIV infection can be in the adrenal function, gonads, thyroid, bone mineral and metabolic disorders. So in fact, all the endocrine functions can get altered in a patient with HIV infection. Of course, that would depend on so many factors like the stage of HIV at which the patient is diagnosed, the patient's current immune status, what is the CD4 count, and what are the other comorbidities the patient is having, what all drugs the patient is taking, all will have a say on what endocrine manifestations the patient is having. So first, we will give an overview regarding the various drugs that are used in HIV and how it affects the endocrine function. There is a beautiful table given in Williams, and there are so many drugs with they have given the organ wise complication of those drugs, and we will see what are the important ones of the selected drugs. With regards to adrenal, the two important points you will have to keep in mind is the effect of ketoconazole and rifampicin. So ketoconazole, as we have learned in Cushing syndrome, it has got inhibitory effect on adrenal steroidogenesis at multiple levels. It inhibits 11 beta hydroxylase, side chain cleavage enzyme, 17 alpha hydroxylase, etc. So due to 11 beta hydroxylase and side chain cleavage enzyme inhibition, they can result in adrenal insufficiency. Also, rifampicin, by a different mechanism. So rifampicin increases the cortisol metabolism, specifically the 6-hydroxylation. The hydroxylation at the 6-beta position is stimulated by rifampicin, thereby it increases the clearance of cortisol. So these are the two important medications that you need to know. Now, gonadal, again, the ketoconazole, it inhibits the 17-20 lyase enzyme as well as the side chain cleavage enzyme. So the production of the gonadal steroids is also reduced, and also the anabolic steroids and megestrol. So megestrol is a progestogenic agent which has been used especially in patients with HIV-induced wasting, and so is anabolic steroids. So both of them have been used in patients for management of HIV-induced wasting, has been found to decrease the gonadotropins. And this megestrol acetate, in addition to that, also has an inhibitory effect. It has got a glucocorticoid-like activity. So it can induce Cushing syndrome-like state in a patient, and it will go and suppress the ACTH, thereby resulting in secondary adrenal insufficiency upon its withdrawal. And in thyroid, the main question would be regarding rifampicin, where it increases the hepatic clearance. So the importance is that suppose a patient on having adrenal insufficiency or hypothyroidism is taking rifampicin, you would have to increase the supplementation doses, because then only you can make sure that the adequate circulating levels are there. Then very important, the tenofovir disoproxil fumarate. So tenofovir is available in two forms. One is the tenofovir disoproxil fumarate and second is the tenofovir alafenamide. So this tenofovir alafenamide is devoid of the bone mineral metabolism effect, whereas tenofovir disoproxil can result in proximal tubular dysfunction, resulting in a Fanconi-like syndrome, where hypokalemia, hypophosphatemia and other features of proximal tubular dysfunction can occur. With regards to calcium metabolism, there are a few points. Very important point is the efavirenz. So efavirenz is unique in such a way that it stimulates the 24-hydroxylation of vitamin D. You know that when the 1,25-dihydroxy vitamin D is 24-hydroxylated, that will cause its inactivation. So there can be functional vitamin D deficiency in a patient who is taking efavirenz. Very important. Okay. Then also this foscarnet. Foscarnet can induce hypocalcemia by complexing with calcium. And of course, we have seen with ketoconazole in Cushing syndrome that it is the antifungal drug or the drug used to reduce cortisol synthesis that can inhibit the 1-alpha hydroxylase enzyme. The 1-alpha hydroxylase enzyme is inhibited and therefore the patient can present with sudden hypocalcemia. And with regards to bone, we have already seen the tenofovir can present in proximal tubular dysfunction. And with regards to glucose, as you know, protease inhibitors are significantly associated with metabolic syndrome, obesity, etc. Body composition, the protease inhibitors inhibit the steroid responsive element binding protein 1 and PPAR gamma. So these two are the important factors that stimulates the adipogenesis or lipogenesis, the steroid responsive element binding protein 1 and the PPAR gamma. So the protease inhibitors, by inhibiting these, will result in the reduced formation of lipid tissue or adipose tissue, thereby resulting in lipodystrophy. And of course, the lipids abnormalities is seen in protease inhibitors. The lipodystrophy can result in elevated triglycerides and anabolic steroids. As we have seen, the most important feature or the lipid profile abnormality in a patient with anabolic steroid therapy is low HDL with normal TG. The most common cause for a low HDL is hypertriglyceridemia. But low HDL in the absence of hypertriglyceridemia should make you think of another etiology, and anabolic steroid is one of the most common acquired etiology. Of course, you have so many inherited or hereditary causes for low HDL like the hypo-alpha lipoproteinemia, Tangier disease, LCAT deficiency, etc. Whereas anabolic steroids is one of the most acquired cause. So you should be aware about all these drugs and their potential effect on the endocrine function. Now coming to the individual hormone changes with HIV infection, the abnormalities, it can result in adrenal hypofunction with reduced cortisol, or sometimes it can present with hyperfunction also with increased cortisol. Now, what is the prevalence of adrenal insufficiency? It is around 15 to 20%. The prevalence of adrenal insufficiency is around 15 to 20%, and the most common cause of AI in patients with HIV is disseminated CMV infection. So, CMV infection is the most common cause, and the other causes include atypical mycobacteria. You can have cryptococcosis, other opportunistic infections like histoplasmosis. Then the HIV infection, HIV adrenalitis itself can result in adrenal insufficiency. But usually the pattern that we see is that the CMV infection doesn't cause diffuse involvement. Usually there will be patchy infiltration there, whereby the prevalence of AI in a patient with CMV adrenalitis is actually low. Even though it is the most common cause, all patients with CMV adrenalitis will not develop adrenal insufficiency because there is patchy involvement. Only when more than 90% of both the adrenal glands are being infiltrated, then only you will get a frank adrenal insufficiency. Now, cause of adrenal insufficiency, we have already seen the HIV adrenalitis comes only after the CMV adrenalitis, which is the most common cause. The other opportunistic infection as well as the drugs that we have seen, the use of ketoconazole, the rifampicin, all can reduce the cortisol synthesis leading to adrenal insufficiency. Now, cortisol excess. Why does cortisol excess occur? Because the HIV itself is a pro-inflammatory state. So, when there is increased inflammation, there is stimulation of the HPA axis. So, HPA axis is stimulated, and therefore, it will lead to, by interleukin 1, interleukin 6, these are the mediators that stimulate the HPA axis. This will lead to increased cortisol production. Then ketoconazole, what does ketoconazole do to the cortisol? It will inhibit the cortisol synthesis. What will rifampicin do? It will accelerate the cortisol clearance. And megestrol acetate, because it has got glucocorticoid-like property, it will inhibit ACTH, and once megestrol is withdrawn, the patient can have secondary adrenal insufficiency. Now, what about gonadal dysfunction? So, male hypogonadism can occur in patients with HIV mainly due to inhibition, like a hypothalamic inhibition of central centers or hypothalamic centers. Chronic inflammatory state that is setting in will have an inhibitory effect on the hypothalamus, reducing GnRH as well as the FSH and LH at the level of pituitary. Also, the drugs that the patient is taking, like the ketoconazole, which induces primary hypogonadism, and also the megestrol acetate, which can induce secondary hypogonadism, the anabolic steroids, all can result in hypogonadal symptoms. Now, effect of SHBG, it causes increase in SHBG levels. So, in fact, the HIV infection can increase the thyroxine binding globulin, sex hormone binding globulin also. So another effect is that when there is increased SHBG, the free testosterone concentration may reduce, because more of testosterone will be bound to this sex hormone binding globulin and the free testosterone concentration may reduce, and this can result in the hypogonadal symptoms, the patient presenting with hypogonadism, erectile dysfunction, etc. And the drugs we have already seen, the megestrol acetate, the ketoconazole, then anabolic steroids, all can result in gonadal dysfunction. Now coming to thyroid dysfunction, the most common abnormality would be a sick euthyroid state, where the free T3 is the one which is having major impact. It will be very much suppressed. Then TSH and T4 will also be suppressed, thus mimicking a central hypothyroidism like state. And just like I've mentioned, the TBG concentration will increase. And very important is the immune reconstitution inflammatory syndrome. That is a patient with HIV who is having very low CD4 count. Once he started on definitive treatment with ART, the patient's CD4 count would increase and the immunological action in a body would also return. In such individuals, the most common clinical manifestation of IRIS in a patient with endocrinological manifestation of IRIS in a patient with HIV is Graves' disease. Graves' disease with the patient may develop TSH receptor antibody positivity, and Graves' disease is the most common manifestation of IRIS in a patient with HIV. Then thyroiditis can also occur in a patient, and the most common cause for infective thyroiditis in a patient, specific thyroiditis in a patient with HIV is pneumocystis. So pneumocystis carinii is the most common cause for HIV specific cause for thyroiditis in a patient with HIV. So effect of drugs, we have learned about rifampicin, which increases the clearance of thyroxine. So these are all the important thyroid related effects of HIV infection. Now coming to bone mineral metabolism, it can result in hypocalcemia as well as hypercalcemia. The HIV infection itself can result in low vitamin D levels, and the ketoconazole will inhibit the 1-alpha hydroxylase, thereby reducing the activated levels of vitamin D, contributing to hypocalcemia. And foscarnet that we use for CMV infection can complex with calcium and can reduce its reabsorption. So these are some of the conditions due to which the hypocalcemia can occur in a patient with HIV, and hypercalcemia can occur with tuberculosis, with lymphoma, or with fungal granulomas. Lymphoma, specifically HTLV1 associated. So HTLV1 associated diseases and other manifestations, then tuberculosis, granulomas, all will express 1-alpha hydroxylase. The granulomas will express 1-alpha hydroxylase, and that will result in active vitamin D3 formation, resulting in PTH independent hypercalcemia. Now about bone loss in HIV. HIV itself is a pro-inflammatory state which increases bone resorption, and apart from that, there are several factors that contributes. One is the hypogonadism, vitamin D deficiency, growth hormone deficiency, effect of drugs, etc. So tenofovir, we have already learned there are two types of tenofovir formulation. You have the tenofovir disoproxyl fumarate, which is responsible for the Fanconi syndrome, and you don't use TDF in a patient with bone related issues in a patient with HIV. We use only tenofovir alafenamide. That is the effect of tenofovir. It will result in Fanconi syndrome in up to 5% of users. Now, very important question is the growth hormone axis in a patient with HIV. So, still now we have been learning that the HIV is a pro-inflammatory state. So, what happens usually in a pro-inflammatory state is growth hormone resistance. So, the feature of growth hormone resistance would be increased growth hormone and reduced IGF-1. So, this is the usual pattern that you will expect. But this is not always the case in a patient who is having HIV infection. So, when the patient, HIV infected patient, is having certain body composition changes. That means when there is excess visceral fat, mainly due to the lipodystrophy. In a patient with HIV induced lipodystrophy, the pattern is that the fat stores from the peripheries will be lost. The subcutaneous fat in the arms, legs, buttocks, everything will be lost, and what remains will be some of the abdominal fat, visceral fat, and sometimes in the nape of neck, which could mimic a Cushing syndrome like situation. So in such patients, the visceral fat would be remaining and all the subcutaneous fat, the beneficial subcutaneous fat will be lost and the visceral fat will remain. So due to excessive visceral fat, there will be increased lipolysis. The lipolysis will increase, the free fatty acids would go up, and what happens when there is increased level of free fatty acids? We have seen that the fatty acids can reduce growth hormone release. So it will result in decreased growth hormone. Okay, so in a patient with body composition change corresponding to increased visceral fat and lower peripheral fat, they would have reduced growth hormone. And growth hormone deficiency has been postulated as one of the important causes for short stature in a patient, in a child who is affected with HIV infection. So that is the role of recombinant growth hormone. One, because there is some degree of growth hormone deficiency, it can improve the height potential in children who are having HIV infection. So when the growth hormone levels are reduced in a patient with increased visceral fat accumulation in HIV, this hyposomatotropism will further worsen the metabolic profile. So they would, low GH would further cause an increase in the visceral fat. So this will continue as a complex cycle. So visceral fat will result in hyper fatty acid like state, will cause reduced GH release, and this reduced GH or the growth hormone deficiency will further worsen the visceral fat deposition. Giving recombinant growth hormone will increase height in children, and also it improves the body composition in HIV infection, improves the body composition, by at least partially reversing the lipodystrophy changes. And one drug that you will have to learn in this area is the tesamorelin. So tesamorelin is an oral ghrelin analog. We have learned about massimorelin, which is again a ghrelin analog, which is approved for growth hormone stimulation testing in adults. So this is again a oral ghrelin analog. What it does is that it will increase the growth hormone release, and instead of recombinant GH injections, it will increase the growth hormone levels, thereby improving the lipodystrophy and body composition. So this is specifically indicated for HIV lipodystrophy. HIV lipodystrophy. This point you should keep in mind. And one more thing, one of the indications for growth hormone in non-growth hormone deficiency state is the HIV induced wasting. So that is the point I am mentioning. The growth hormone supplementation would improve the body composition in a patient who is having HIV infection. Now, what about the glucose metabolism in HIV? This being a insulin resistance state, chronic inflammatory state that will result in peripheral insulin resistance at the level of adipose tissue, at the level of muscle, and the increased fatty acid generated as a part of visceral adipose tissue metabolism also will hamper the glucose metabolism. So there will be increased hyperglycemia, insulin resistance. Insulin resistance, this is the usual glucose metabolism abnormality. Now, what about the lipodystrophy? So, lipodystrophy, that just like I have mentioned, the fat lost in limbs, buttocks, face, whereas it will be preserved in visceral adipose tissue. That means mainly in the abdomen, visceral adipose tissue, and sometimes in the neck region. So this can mimic a case of Cushing syndrome. Okay, Cushing syndrome may be mimicked by HIV induced lipodystrophy. Okay, but it is readily evident by the significant muscle wasting and all which occurs in HIV. So lipodystrophy versus HIV. How do you differentiate primary lipodystrophy versus HIV wasting? Mainly the abdominal fat is preserved. So abdominal fat is the one which is bad for us. Okay. So abdominal fat is preserved in HIV, whereas in in generalized lipodystrophy, fat everywhere is lost. That is why there occurs ectopic fat deposition. Abdominal fat is preserved in HIV. The risk factors for lipodystrophy in HIV, they include advanced disease, low CD4 count, the use of protease inhibitors. You know that protease inhibitors also will reduce adipogenesis by two mechanisms, by reducing the steroid responsive element binding protein 1 as well as by reducing the PPAR gamma action. What are the metabolic complications? The most significant is the increased triglycerides and low HDL. So increased triglycerides and low HDL. Due to anabolic steroids, this triglyceride cannot be explained, but as a part of lipodystrophy and metabolic syndrome, the triglycerides would be elevated, HDL would be low, and LDL will also increase. And the treatment you give accordingly. There is no specific treatment for dyslipidemia or lipodystrophy in HIV patients, but you can try certain agents like, you know that the protease inhibitor inhibits the PPAR gamma. So when you are giving pioglitazone, it can partially cause some improvement. Okay, pioglitazone. That growth hormone can cause some improvement. Metformin has been found to have some beneficial effect. Then previously some other medications like thalidomide have also been used in lipodystrophy, but again currently not used. So at present we may use pioglitazone if the patient is having coexistent diabetes also, and growth hormone is given in eligible patients, and metformin is also given if it is not contraindicated. So summary, in this area HIV and endocrinology, so the major thing that you will have to learn is about the drugs, the effect of drugs, and what the enzyme inhibition, the enzyme stimulation, what are the drugs and where does it act, and few points with regards to each of the organ involvement, which is the most common and least common. Some points I have mentioned will also keep in mind. Also keep in mind the tesamorelin, which is an oral GHRH or the ghrelin analog, which is used in the management of HIV induced lipodystrophy.